Thank you, Nancy Thompson and Mike Oliveris, for his last-minute technical assistance. And I want to welcome everyone who's participating through this webcast. I want to acknowledge my wonderful staff who's back in the office keeping down the fort and who's also watching this presentation. As Nancy said, I am a geriatric dentist. I am a former faculty at the University of Texas Dental School. But perhaps more importantly, I want you to realize that I was a certified nursing assistant many years ago in a nursing facility. And I am also the daughter of two aging parents. So you can see that I'm very excited to be able to speak to you, the caregiver, and to be able to actually show you some of the things that I've experienced along with you. For example, I, like you, have experienced the joy, the fear, the frustration, the exhaustion that can come with those of us who have been on the front line of caregiving. I was reminded this in a very dramatic way just a couple of weeks ago when I had to make an emergency trip back home to my parents' house because my mom was hospitalized. I found myself in a position where I had to become the primary caregiver for my father, who has dementia. So like a good dentist daughter that I was, I asked my father to brush his teeth. A few minutes later, I went into the bathroom to see how he was doing, and he had actually taken a comb, put gel toothpaste on his comb, and was applying toothpaste in his hair. And if that wasn't bad enough, when I then took the toothbrush and started brushing his teeth, I was astounded by the amount of blood that I saw in his mouth. So you can imagine when he was spitting blood into the sink, I felt not only like a failure as a dentist, but I felt a failure as a daughter. So I'm including myself when I talk to you about some of the frustrations and challenges that we have as caregivers on the front line. And I'm here to tell you that we cannot do it alone. I cannot do it alone. You cannot do it alone. And we have to look to the support and the expertise of the entire community who's dedicated to helping the frail elderly. And that begins with awareness. And that begins with the acknowledgement that basic routine dental care is essential, especially in the lives of the frail elderly. This presentation is actually the first of a two-part series. Today I'm going to go over some basic concepts about awareness and goals. The next presentation, which is in May, will actually go into more of some of the specific techniques that we can use to provide daily care for the elderly. Because as you know, if you are a primary caregiver, brushing the teeth is a lot easier said than done, especially if you have someone who's not cooperative. So what we'll focus on today is some of the unique barriers to oral health in the frail elderly. We're going to really appreciate our role as caregivers in the early recognition of certain problems. We're going to identify some of the most common problems, and then we're going to end the presentation today by discussing the concept of priority-driven care and also the idea of oral neglect in the elderly. As you know, as frontline caregivers, there is a lot of barriers to the elderly receiving care. In fact, it's no surprise that the elderly have the greatest oral health needs, but yet they receive the least regular oral care. These photos represent just a small percentage of the things that I see on a daily basis. These problems started out as very minor problems, but can quickly become serious problems. But I'm here to say that you can make a difference, I can make a difference if we team up together and we utilize the resources and expertise of other people who have the same mission as we do. For example, occupational therapists can help team with us, physical therapists, DONs, nursing administrator directors, dental hygienists, CNAs. So we have to look at everyone supporting each other in order to make a difference. Now we all know that the good news is that we're living longer and we're living longer, healthier lives. This is one of my all-time favorite patients. He's 103 years old. And when we asked him if he could walk, he jumped up and said, "I can dance and I can skip." He is not who we're talking about today because he is almost fully dependent. He is able to take care of his own oral hygiene, and as a matter of fact, he got a couple of implants just a year ago. But the other side of the coin is that we are just living longer. With the advances in medical care, people, frail, elderly people, are living longer and longer with very complicated, debilitating diseases, physical and cognitive limitations that will limit even their access to basic care like daily oral care. So as a dentist, since their care and their access to care is so limited, by the time they come to my office, these problems are usually quite extensive and quite serious. So hopefully by the end of today, we're going to see how we can do some early detection, early prevention, so that it doesn't become a catastrophic problem. This is a pretty common slide that most of us have seen, but I want you to focus on that bottom curve, the white line, which is a curve that shows the aging of the old, the 85 and older. Most of the frail elderly that we're caregivers for will be in the old range. So for the purposes of today, we are going to focus on those individuals who probably need a lot of help with multiple activities of daily living, and the oral care is just one of them. So who are the frail elderly? Well, they're obviously most of our, if not all, nursing home residents. A big proportion for you primary caregivers at home that have a spouse, a sibling, a child, or a child of an elderly person. They may live in the community, and they may be functionally dependent on you for certain things. It may be a partially independent or partially dependent community dweller. But what is the consistent thread is the frail elderly are, in terms of dental care, they will have limitations that will complicate even routine dental care. So how do we overcome these barriers? Well, in our office, one example is many of our patients are on Coumadin, so that we actually take a INR in our office because we don't want to have a simple, easy 2-minute blood test to limit our ability to, for example, do a thorough oral debridement of the mouth. So this is just one example of something that could seem like a huge barrier, but if we use a little bit of creativity, we can overcome some of these barriers so that it does not prevent good care. In every situation with the frail elderly, we have to do an overall assessment. This is a patient that I had at the dental school who was actually quite independent, lived by herself, but because she was so medically frail, even basic care became a problem. Although she technically needed a lot of crowns, in light of her entire situation and in her best interest, we could only focus on those procedures that would eliminate pain and manage her infection. I really love this slide. This is a slide that I took when I was getting my geriatric training at the VA. We see a picture of a 90-year-old uncle who you can see is clearly happy, clearly well taken care of, but look in the back. That's his caregiver. That's his 70-something-year-old niece who has her own limitations. So I want to remind all of us, as I am reminded as a caregiver, that I too have limitations. We have time limitations, we have family obligations, so we cannot lose the fact that we also have to face our own limitations. It reminds me of when I was a nurse's aide and I would have a wing of patients that I had to get up in the mornings, and you had to dress them, give them some basic hygiene, you had to toilet them, get them into the dining room for breakfast in a matter of 15 minutes, and quite honestly, there may just not be that time that you want for oral care. In the frail elderly, oral problems are often more severe, and that's because they're not noticed till they're very serious. Infections are not always symptomatic. There may not be a fever if they have an infection. And this is complicated and made worse by poor or inadequate oral hygiene. The elderly's oral needs are not often expressed. And then even if they are expressed, even if we do identify a need, there is some basic lack of access, such as transportation, to even receive this care. This is an x-ray of a patient that I had many years ago who, it was actually kind of terrifying once we finally got her referred to our office and we took an x-ray. You can see that she has one obvious tooth with a crown where there's decay going up under the crown, and then we have another tooth to its side where you can see it's broken up at the gum line. By the time this patient had gotten to my office, there was such an infection in the bone that I had to refer her to an oral surgeon. And I'll never forget when I was talking to him on the phone, and he said, my main concern is that when I remove those teeth, her jaw may actually break. And this is a problem that could have been seen much earlier if we had simply been in a position where this patient was given the opportunity to have an annual exam. Now, a visual exam is a place to start, but without x-rays and with just looking at front teeth, it can be particularly deceptive because a lot of the problems that we see can actually be in the back. And unless you have a lighted mirror, unless you're a trained dental professional, it's very easy to miss problems that are in the back of the mouth. What we're going to do now is I'm going to move on to some of the common oral disorders that we see. There are dozens and dozens of less common, more exotic things that I may get referred in my office, but we can sift down the problems that we see in the frail elderly to about 5. And that's what we're going to focus on today. We're going to look for the horses. We're not going to look for the zebras. The zebras will come up, but 99.99% of the time we can focus on these 5 basic oral problems. All of these photos represent these 5 oral problems, but unfortunately it represents these problems that have progressed to be quite serious. So we're going to start with gum disease, and gum disease, also called pyorrhea, periodontal disease, is a chronic infection of the supporting tissues surrounding the teeth. Most basic cause is bacteria that gets lodged down into the gums, the bone. We get bone loss. We start to get teeth moving. And then we get to a situation like this where it's very, very serious. There's a saying that the mouth is the window to the soul, and you can just tell by looking at this woman who was cognitively intact that her soul is suffering. This is one of the most difficult patients I've seen in a while. Her teeth were so mobile, so covered with calculus, the teeth were actually bonded together. They were so loose that we were afraid by the time we saw her that she might be at risk of aspirating some of these teeth. So what do? Well, the first step, the most basic thing to do, is to come up with a personalized daily oral care plan for the caregiver. Yes, it's easier said than done, and on my presentation in May, I'm going to come up with some strategies because I realize that one of our biggest obstacles is the provision of daily oral care. For example, we know that with our patients, we've just put a toothbrush in their mouth, and you may get, because the mouth is sore or there's infection, you may get a lot of resistance. So how are you going to adequately provide this care if you have a lot of resistance? To show you an example is also, if you have the time, if you have the motivation, you have the tools, as a primary caregiver, you will not be able to get the patient's mouth back to square one. So as a dental professional, you have to employ the expertise and skill, and sometimes it takes multiple providers to get the resident, to get your loved one back to a physiological state of health. I took this picture because I think this was a new record in our office. If you look carefully, you will clearly see 4 people, but we actually had 5 people that were necessary in order for us to get this woman's mouth back to a situation where the primary caregiver could maintain it. She was a high aspiration risk, so we had a suctioner. She was not completely cooperative, so we had to hold her hands down. And it was actually for us, who are trained and experienced, quite a chore to get her to where she needed to be. I'm not going to talk about actual techniques today, but there are some techniques that we'll talk about in May that will really make your task a lot easier. The first common problem I talked about was gum disease. The second problem is rampant decay, and that's widespread destruction of teeth due to cavities. And I want to emphasize widespread. It's very unusual that by the time someone comes into my office, they have one cavity. Usually it's a situation of you have 28 teeth, you have 28 cavities. That's complicated by the fact that the elderly also have a lot of gum disease. So as you can see from this x-ray, when there's a lot of bone loss, there's a lot more tooth surface for the bacteria to stick, food to get caught in between the teeth, so that someone can quickly progress to having decay on all of their teeth. Some of the signs that you'll see is you may see black teeth, broken teeth, sharp teeth. They may have a foul odor or not. They may or may not have pain, and they may or may not have swelling. This is actually a pretty common scenario that we see here. Here we see obviously someone who's had regular dental care, because you can see those gold crowns in their mouth. And probably what happened is they have gotten regular care throughout their whole life. Maybe they turned 75, 76, 80, and they had a catastrophic medical decline, like a stroke, a heart attack, and their whole life got turned upside down. You as the caregiver then had to find a place for them to live. Everything had to be changed. And for a period of only maybe 2 or 3 years, the mouth was inadvertently neglected. Well, you can see what can happen in just a matter of years. In a matter of 1 or 2 years, if there is no regular oral care or no dental intervention. Some of our common treatments that we may use with the frail elderly, we may not be so apt to use with someone who's younger. For example, one of our treatments that we may do is just a sedative filling. Sedative fillings are medicated fillings that we can put in someone that has rampant decay, that is quick, economical, and that can maintain and try to stabilize the situation before we can do more definitive care. We can do extractions, we do a lot of fluoride, but sometimes we have to realize that the better part of valor is just to monitor teeth. We have to weigh the risks and benefits of treatment. If we try to do a filling on a third molar, are we actually putting that patient at an aspiration risk? And then our basic goal is we have to try to keep salvageable teeth serviceable. I'm always telling family members our goal here is not perfection. What we want to do is we want to maintain teeth as long as they are serviceable, not causing pain, not causing discomfort, so they can use them to be able to eat with. The third scenario I want to talk about is dry mouth. Dry mouth is extremely common. If I have 50 patients come into my office, probably 49 or 50 have dry mouth. That's the reduction of the watery, primarily the watery saliva in your mouth. We have 2 kinds of saliva. We have the mucousy, kind of sticky saliva, and then we have the watery saliva. Medications tend to dry out the watery saliva. So what we're left with is either no saliva, or we may just have that very sticky, mucousy type of saliva, which tends to then have the plaque stick much more firmly to the teeth when it's the viscous type of saliva. And once again, we can get it in a situation very quickly where the mouth is so sensitive because of the dryness that it's difficult to even put a toothbrush in the mouth to provide the necessary oral care. This is a picture of really the worst case scenario of dry mouth. We have someone who probably went almost their entire life without any cavities. And now that because of medications and lack of adequate daily oral care, you can see how that plaque sticks on her teeth like super glue. This is actually a picture that I think we took a couple weeks after we did a thorough oral debridement. So just in a matter of weeks, her mouth ended up looking about like what it looked like when we first started. With the dry mouth, you're going to see shiny gums, shiny tissues. Have your elderly resident or loved one stick out their tongue. If it's very fissured, you know they have dry mouth. The person is going to complain of a sticky feeling. They may complain of a burning sensation. And they're going to have a decreased ability to taste foods and even swallow. And one thing that we may not think about is that saliva is necessary to have dentures get that suction that we need to be retentive. So the lack of saliva also causes a problem with our denture patients. Unfortunately, since saliva is so critical and dry mouth is almost universally a problem with the frail elderly, we often see, because of the lack of saliva, teeth start breaking off. And it actually very adversely affects just the basic comfort of the mouth when it's so dry. It feels like you have sandpaper or you've been to the beach. Even if you don't have teeth, dry mouth is painful, and it can make ulcers and denture-related injuries much more significant. Here's a patient that has a lesion caused from a rubbing denture that might have not been quite so painful if they had had adequate saliva. Now, it's very difficult for you to see these lesions in the mouth at times unless you have a lighted mirror and you have really good visibility. So these lesions can be overlooked. Well, what are the common treatments? I tell caregivers the best treatment you can do is water. Water, water everywhere. Like I had a really sharp woman tell me, water, water everywhere. She was a nursing facility resident and not a drop to drink. I understand that, and it's very difficult for you to have water in a cup at all times for the elderly to be able to moisten their mouth. So one of the suggestions we make is to buy one of these small little squirt bottles like I have in the slide there, where someone with poor dexterity can actually hold that in their hand and periodically spray their mouth with a mist of water. I think this is really useful also for patients who may be in aspiration risk, they had difficulty swallowing, and it's just a way to provide comfort. There's saliva substitutes on the market, but still I think nothing beats plain water. And if you do choose to use a rinse, please use a non-alcohol rinse because alcohol is very drying to the oral tissues. And there are water-based alcohol rinses that you can use. The fourth common problem that I want to talk about is candidiasis or yeast infections in the frail elderly. It is not quite as common perhaps as gum disease, decay, and dry mouth, but I see a case of candidiasis, usually 1 or 2 cases every single week. Candidiasis is a yeast or fungal infection caused mainly by the Candida albicans yeast, and we see it very frequently in the elderly who are on antibiotics. And as you know, the elderly are on antibiotics for urinary tract infections, maybe respiratory infections, maybe the dentist put them on an antibiotic. And once the bacteria in the mouth start to get killed, what happens is the yeast that's already living in the mouth naturally starts to overcolonize and overgrow, and then that's when the problems start to happen. Some of the signs, as we've learned throughout the years, is those white curdy plaques we will see. But interestingly enough, it wasn't until I focused strictly on geriatrics that I began to notice that actually I see a lot more of the atrophic red erythematous type of candidiasis than I see the curdy white plaques. I'll see for every of the white plaque patients I see, I'll see about 40 of the patients who have just the very red type of pain, burning type of candidiasis. So this is important for you to know. If your loved one, if your resident is complaining of a burning mouth, it could be very likely that they have an acute candidiasis infection that is made even more painful by the fact that they have a burning mouth. Candidiasis loves to colonize on dentures, so this slide is just a reminder that when we treat the mouth, we also have to treat the dentures or the partials. So if you suspect your resident or your loved one does have candidiasis, you want to refer them as soon as you can to a dentist or a physician who can start appropriate antifungal treatment. There's a lot of antifungal medications on the market, but for the frail elderly, a lot of these interventions are not good risk-benefit. They can cause liver problems. They can cause all sorts of adverse side effects. So generally, we stick with an antifungal called nystatin. One of the things I've learned over the past few years that nystatin typically is the way you dispense it is you ask the person to put it in their mouth and swish for 2 minutes. Well, any of us who are primary caregivers or who have worked with the frail elderly know that the frail elderly cannot swish for 2 minutes. Most of us can't swish for 2 minutes. And the nystatin can only work while it's in contact with the mouth. So that's why one of the reasons I think we see some poor resolution of candidiasis in the elderly. So one of the things that our pharmacist came up with us was we asked them to formulate, once again, the same kind of spray bottle where the suspension of nystatin is put in the bottle, and then the nurses or the family member can actually spray that in the mouth, and there's no need to then swish. We also asked them that the dentures are sprayed or that the dentures are soaked in the nystatin solution, because if you don't kill the candidiasis in the prostheses, it's just going to come right back. Part of the picture of candidiasis is also something that we call angular colitis. Angular colitis may not be a phrase that you're familiar with, but it is something that family members and nurses' aides actually see quite frequently. What that is, I'd like to show a picture of it and then go back to this slide, is it's the painful cracks that you see in the corners of the mouth. Now, these cracks can be caused by dry mouth, over closure of the mouth so that these cracks get kind of deep. But what they're the reason they generally don't heal is because it's invaded by a fungal or yeast infection. The typical scenario that I have that comes in my office is I'll see a patient and the daughter or son will bring the patient in, and I'll say, did you notice that your loved one had these cracks in the corner of their mouth? And inevitably, they'll say yes. And so we have mom putting Vaseline on or Carmex on. And so we do recognize these cracks. But what we may not recognize is that our good intentions are actually have gone wrong. Because if we put Vaseline or Carmex on these yeast infections, we actually inadvertently are decreasing the ability for this to resolve. So what then we must do is we must put the patient on a prescription of, I use Mycolog 2, which is an antifungal steroid cream, and then the caregiver will apply that to the sides of the mouth for up to 21 days. This is a patient who the cracks were so deep, for the picture I had to pull her lips apart so that you can just see how deep, and actually this photo doesn't do justice, how deep that crack was. And the reason for her problem was that her dentures were so worn that her mouth had closed many, many millimeters over the last 20 years. So in addition to this antifungal cream that we put, we also then prescribe the antifungal nystatin spray. And then sometimes it's necessary to even make new dentures to open up the mouth again to get full resolution. The last common problem that I want to cover is denture-induced injuries in the frail elderly. We talked about gum disease, decay, dry mouth, candidiasis. I see denture-induced injuries almost every single day. Traumatic injuries can come from wearing full dentures, partial dentures, or as I'll show you a little bit later, just from missing teeth. The causes can be a poor fit. Mom's worn her same teeth for 20, 40 years. They may wear them at night. Then we get bone loss, poor oral hygiene. And in the case that I'm going to show here is, here's a photo I took of a patient who was a very interesting situation, and I'll never forget how devastated the daughter was when I showed her her mother's mouth. What happened was the daughter brought mom in because mom was complaining of a toothache. The daughter did not know that her mother had worn a denture, or a partial denture, so that when I took out the partial denture, the daughter for the first time realized that the front tooth was actually a denture tooth. And when we took that out, you can see the traumatized tissue underneath, and where you see the wide area, that was an ulcer that had invaded all the way down to the bone. So you may ask yourself, well, how could this go on for so many years and no one noticed? Well, if you think about it, our elderly often can't complain, won't complain, and are there on multiple pain medications that may mute the pain. But this is another example of good intentions. The daughter got her mom in quickly, just didn't realize that her mom even wore a partial denture. Some of the signs that I will look for would be red tissues, bleeding, ulcers, swellings, maybe tissue overgrowth. But what you'll want to look for in some of the complaints would be pain. Mom can't wear her dentures anymore, or she can't eat. If you take out the dentures and they look like this photograph where you see a lot of breakdown, I assure you that in their mouth they have multiple areas where they're going to have traumatized tissues. This is a photograph I took just of a patient last week who, because they were missing teeth, and the teeth actually provide a protective mechanism by how they overlap. So if you're missing teeth, the lip might sometimes get in the way, and this patient had bit a quite deep, painful hole in his lip that could only be corrected if we made him partial dentures. If the person that you're a caregiver for, whether you're a nurse's aide or a family member, if they wear partial dentures, I would say 95, 98% of the time they're going to have also gum disease, decay, dry mouth, candidiasis, a mouth odor, and a denture injury. The reason for that is because although partials are very useful for mastication, for chewing, for looks, they are notorious for serving as places where food and bacteria can lodge. So if you couple that with a patient who may have dexterity limitations, they no longer can get their partials out to brush, they may have good intentions, but it's just not adequate, you can quickly get to a catastrophic situation in the dentition. So what are some of the common treatments? Well, we can make a denture adjustment. In fact, I want to show you this slide, which looks terrible. You can see how deep that ulcer is. This is me pulling the lip out. You see a very deep ulcer. You see how the tissue has grown up. But all it took to resolve this problem was to adjust the denture. The denture was overextended because of all the bone loss. We shortened the denture. We put a tissue conditioner in the mouth so she could wear the denture and still be comfortable. Our patients sometimes just need to rest the tissues, hydrate the tissues, and if nothing else works, they may actually need some new dentures. Okay? I'm going to finish up the presentation today with a couple more topics. We're going to talk about oral neglect in the frail elderly, And I think that this is an idea that we've heard about many, many times, but it's now becoming more on the forefront. And I think as nursing administrators, as caregivers, as individuals who work in mainstream health care with the frail elderly, we have to be aware of what's happening in terms of definitions of oral neglect. And the bottom line for this is that I'm going to show you a current published definition of oral neglect. And I think that this only brings to light the importance of timely detection and referral, and to also take one step back where we need to provide annual examinations for every single one of our residents, every single one of our frail elderly that we have under our care. And that, quite frankly, is the exception and not the rule. About almost exactly 1 year ago, April 2010, in the Journal of the American Dental Association, which I encourage you to look this article up. I'm only going to talk about it for a brief minute. It's beyond the scope of this presentation to go into any detail. But a group of academians, researchers came up with, they called a utilitarian definition of oral neglect. And basically, it's expressed in a number of days. For example, if you have an acute problem, how much time has lapsed between identification of the problem to the time where you get a oral care professional or a medical professional to actually diagnose the problem? How much time does that take? And then there's another time frame of how long does it take from the time of diagnosis to the actual time of the initiation of treatment, completion of treatment, and or refusal of treatment. One of the things that is associated, I think, from a legal perspective, and this is what worries me a little bit about the fact that there is now a definition out there. I'm not saying that that is the definition, but I think we have to be aware of it, is the frail elderly are at risk of aspiration. And we can imagine that if someone has gum disease, rampant decay, dry mouth, and a yeast infection, they're at very high risk of aspiration if they do not have regular oral care. This was a patient that was referred to me and by a nursing facility, and the nursing facility had literally tried for months to try to get an intervention for this patient of theirs, this resident of theirs. So should we throw them under the bus for oral neglect? I think not. If you look at the hurdles, and sometimes it's impossible to get the proper basic care that these residents need. As a reminder, even if you can get the care, is it realistic on a daily basis for a facility to have multiple providers to provide this care? So you can see that it's a real problem, and one that my opinion is that mainstream dentistry has really got to shoulder the responsibility for trying to come up with sustainable solutions that are creative and to spearhead new strategies so that oral neglect is not such a frequent problem in the facilities. I'm going to flash through this slide really fast because it's actually pretty disgusting. But as you can see by that previous slide, we have dentures that are covered with debris, covered with food, covered with bacteria, so that if you have a loved one who's wearing a denture, these can also serve, even if they don't have teeth, as a put you at very serious risk of aspiration, bacteria, and food. I want to finish up here with the concept of a dental downward spiral, which we see all the time, and that's where you have a loved one who is, has a decreased ability for self-care. They get a dry mouth, they get cavities, they get mouth pain, they lose their teeth, they can't chew, they change their diet, they can't get to the dentist, and what we have quite frequently is now their diet suffers. They may be on a mechanical soft diet, but because of their catastrophic decline in their oral health, the physician has no choice but then to put them on a puree diet because they can no longer chew. On the more positive note, though, what we can do as when we intervene is to try to upgrade the diet and have a positive impact, and this is more what I want to focus on. If someone is on a soft mechanical diet, what can I do to get their mouth back to health so that they can then be put on perhaps a mechanical diet? I wanted to put this slide in here as a reminder to all of us that eating is not just about ingesting calories. Eating from birth to the grave has a lot of emotional, spiritual, psychological, social implications, and one of the most basic pleasures in life. So that when we think about what our role is, we want to remember that eating is one of the pleasures of life that never go away. So as a caregiver, we want to detect, refer, and we want to partner with our team, whether it's the dentist, the nursing facility, primary caregivers, to focus on priority-driven care. And my last couple of slides are going to illustrate this point on what is priority-driven care. Priority-driven care begins with daily oral care. If we have a resident who needs 28 extractions, that doesn't mean that those 28 teeth do not still need to be brushed and taken care of every single day. We may focus on, instead of doing complicated, extensive dentistry, we're going to focus on the management of oral pain. We're going to focus on the management of discomfort. We're going to try to eliminate oral infection. We're going to orally debride the mouth. We're going to try to keep salvageable teeth serviceable with the ultimate goal of enhancing and maintaining nutritional intake. So when we look at what our role is and what priority-driven care is, it is more of a focus on maximizing quality of life and dignity, and not so much a focus on the most complicated dentistry that may be available to us. As caregivers, this is what we see all the time, but this is our goal. This is our goal, a healthy, happy mouth. I think that's it. We've got some time, I think, for some questions and answers, and it looks like I have a question here. Here's one from a viewer. Can I expect staff at the hospital and nursing home to provide daily oral care to my mother? I love that question. I love that question. You know, in a perfect world, yes. In a realistic world, I can say that it's probably rarely done consistently on a daily basis. And I'm not trying to make excuses, but I can say that even for the basic nurse's aide, she is not given the tools necessarily, or the time, or the training to be able to actually provide this care. And for her to be able to provide the care, whether you're in a hospital or at a nursing facility, the mouth has to be brought to a certain physiological comfort level so that a toothbrush can be applied and a toothbrush can actually be effective. We have another question here, is how does nutrition affect oral health? Nutrition can affect oral health in very dramatic ways, especially in the frail elderly. The frail elderly who may not have access to possibly the kinds of foods that are naturally self-cleansing, like apples and fruit. They may not be able to swallow those kinds of foods. They may lean more towards the soft, rich, high in carbohydrate and sugar food items, so that when they chew that, it just exacerbates the problem. They get more bacteria, more decay, and then they could be destined to actually all soft foods. And I have a lot of patients who are now only able to eat soups or may even be on a puree diet because their oral health has been so negatively impacted. Well, I don't see that there's any further questions, so let's go ahead and I think we're finished here. I want to thank you everyone who participated in this live webcast, and we look forward to presenting another series for you in a month. Thank you.
Thank you, Sarah. Well, I always think about what I'll take away from this, and today this reminded me about how important hydration is, and we've had other programs about hydration, but I had not thought of it in such specific connection to dentistry and oral hygiene. I love the example of using the spray bottle for maybe someone who has arthritis. And think of what relief that could provide someone each day who has that dry mouth. So if I take nothing else away today, that's something that I'll do for someone that I'm caring for, or offer as information to someone I know who's caring for an elderly loved one. We want to again thank our donors and partners, the Baptist Health Foundation of San Antonio, the Methodist Healthcare Ministries Foundation, the South Texas Geriatric Education Center, the Prior Trust, and the many other individuals and organizations who support the mission of mmlearn.org. Okay, do not forget, go up to the top of the screen, click on the survey, and complete that. It's going to take you less than 5 minutes, and it's very important to our funders and to us that we collect information about how effective our programs are. We will offer this particular Ask the Geriatrician program for only a 45-minute CEU, and if you have any questions, you can email me at info@mmlearn.org. What I'm really excited about is coming back next month and learning more about the specific things that we can do as caregivers to address this problem. You know, I didn't know some of these things when my dad was in the hospital, and I wish I had. I can't change that, but I can change it in the future. I can educate other people around me, and I hope that you consider this as something for you to share with other people. Knowledge is power, and whatever you learn today, if you share it with others, it may improve the life of an older adult. So thank you for joining us, and we will see you next month. And Sarah, thank you very much. It was excellent.
Thank you, Nancy.
Thank you.